All right, well, I'm going to say we have a quorum now. Uh, Shake, if you're ready.
I'm ready. Yeah.
My uh, my honor to present our grand round speaker for today. Rich is in Normandy, France, this week, so he's unavailable. Um, Everyone knows Dr. Shaker well. He is a professor and vice chair of our department. He's the director of our cerebrovascular division and the skull base, a co-director of the skull base division at UW neurosurgery. He has a long and distinguished career, which we could never possibly, recapitulate in a few minute introduction here. But some highlights is that he's been president of the World Federation of Skull Base, the Washington Association of Physicians of Indian Origin, the Majid Sami International Society, and the Washington State Association of Neurosurgeons. He has, an academic career par excellence, over 400 publications. He's editor of the widely acclaimed textbook of neurosurgery that all of the residents have, and many hundreds and if not thousands of neurosurgeons have enjoyed over the years. Astonishingly, he has an H index of 98, which I didn't know it could go that high. It's fast, just phenomenal. It just speaks to the importance of the many publications that he's had over the decades of a very storied career. But I think I want to conclude by saying that Dr. Shaker is absolutely, without a doubt, the best teacher in our department. He teaches students, residents, faculty, experts. He teaches at all stages, and he does it with patience and grace. And I just want to quote a statement from his CV that I had a chance to look at yesterday, and this is from Dr. Shaker himself. Quote, I believe that the Atman exists in all beings, and therefore all living beings are equal and deserve the greatest degree of respect. Following this philosophy, I believe in treating everyone with respect and kindness. I pay attention to people who belong to minority communities and to women in our educational process. I welcome numerous observers in the OR from all parts of the world and diverse backgrounds. And those are all tenets we all should live up to. So thanks, Shake, for giving grand rounds today. We really look forward to it.
Thank you, Dr. Kim. It means a lot to me to hear you say these words. You are one of the great leaders of the department and great leaders of the future. And we have many, many in our department. Of course, Dr. Ellenbogen is not here. So Dr. Ellenbogen asked me to speak about skull-base surgery, the historical aspects. But what I thought I will do is to integrate that a little bit with my personal philosophy and then how it evolved to some extent. A brief, it's very difficult to address the topic as the whole, but very short segments about two areas, namely the development of carotid artery management and some perspectives on cavernous sinus surgery. But I'm going to conclude by looking at innovation, which is very, very critical to our resident and fellow group. So these are some disclosures. The good news is that none of these companies have any relevance to this presentation, and neither do they generate any income. So we'll start by thinking about what is it that we do as neurosurgeons, and also skull-base surgery falls in this category. And some of the young people may not know this or may not be followers, but people in my generation were addicted to this the show initially started as a low viewership, but then gained a lot of viewership. Star Trek, and there are two characters there. Spock, who was very far popular, is from a particular planet where they think logically, and Captain Kirk, who is from the planet Earth, who thinks like us emotionally. And Spock is like the scientific officer. And in two episodes, the first one, Spock says, logic clearly dictates that the needs of the many outweigh the needs of the few, or the one, which is Captain Kirk completes what he wanted to say. And if you think about it, this is what our ID doctors do all the time. So we don't worry about the sacrifice of a few people in search of vaccines or other things so that the entire population is gained. But in Star Trek 3, Search for Spock, then the crew of the Star Trek go and rescue Spock, who is stranded or who is abandoned, just to save the other people. So let's start with this here. Increase the sound a little bit.
The needs of the many outweigh the needs of the few. My father says that you have been my friend. You came back for me. You would have done the same for me. Why would you do this? Because the needs of the one outweigh the needs of the many.
So this is what we do as neurosurgeons. We just take care of one patient at a time, one life at a time. And we believe that just saving one patient, one life is going to be very, very important. This is also actually derived from some other philosophies. The Talmud says that whoever saves a single life is considered by Scripture to have saved the whole world. Something similar is also in the Quran. The U.S. Marines have this motto: we'll leave no man or woman behind. And we are Marines in neurosurgery. We leave no man or woman behind. So the question then comes up, is one life as important as the lives of many? Should we fight to save one life while thousands are being killed in Ukraine or are dying of hunger, etc.? I can't answer these questions, but as neurosurgeons, we're just fighting for one life and the quality of life, one patient at a time. Population health doctors and ID doctors who are abundant, fighting the other, both are important. Briefly about my personal background, which has something to do with which will evolve, and it'll show you why it was important as skull-base surgery developed. I was born in Madras, India. Now it's called Chennai. I grew up in a small town, and I was educated in average public schools. Tamil was the medium of instruction. And I got very high marks in the high school, and I got into a very elite college in Chennai. It was run by the Jesuits, called the Loyola College. I finished with the second highest score in the final exams. However, because I was a Brahmin, I faced very severe reverse discrimination, and only 2% of the seats were available for the so-called forward communities. 98% were reserved for other people. And my strong preference was not to become a doctor, but to become an engineer like my uncle. But my dad really forced me to become a doctor, and I couldn't go against the wishes of my doctor at the time. I joined Madras Medical College of Madras University, and I also graduated at the top of my class. I eventually decided to move to the USA, mainly due to this very strong discrimination against forward community. So here are some pictures. This is the state of Tamil Nadu, and this is where I grew up. This is where I was born, and this is where I grew up. And then this is a big falls it's called Hogenakkal, the River Kaveri, which is very famous. This is Loyola College in Madras, and this is Madras Medical College. This is called the Anatomy Block, a very old institution, and the big hospital, and this is the beach in Chennai. So this will lead to an evolution of my personal philosophy, which has something to do with the way I approach life and also approach everything. So I won't go into details, but I believe that everyone is a tiny part of the Brahman, and we are all equal, no matter what you are. And all beings, human life, animals, plants, everybody is equal. And we should treat others with respect. We may not be able to love other people, but we treat them with respect all the time. And we have to listen to other people carefully. And we're just like actors. We act our bodies, act our parts from our bodies, which are determined by karma and dharma. So what is dharma and what is karma? Dharma is a concept which refers to actions which benefit all people and do not cause intentional harm. But it does allow violence or aggression to protect yourself, one's family, or others who inflict harm. It also refers to one's prescribed duty to yourself, your family, teachers, to work, Mother Earth, etc. Karma refers to action and also to the sum total of actions. It can be viewed as a bank where good actions and bad actions build up over time. Another important question that may be asked, and it's a subject of great debate: does the Brahman, the universe, respond to prayer? And this is again very beyond scientific proof. My own personal feeling based on experience is that yes, in my case. So what's our dharma as neurosurgeons? Be kind and compassionate to all, treat all humans with respect, but also expect that they will perform to some standard. Always help your patient to the best of your ability. Build a team around you and help all members of the team. And if you're not able to perform a job well, ask for help and try to innovate, improve your performance every day, and also to innovate and evolve constantly. Now, fast forward to 1980, starting residency at the University of Pittsburgh under Dr. Peter Janetta, who's an incredible person, very, very charming and handsome. And some of the modern generation of residents may not know he's the originator. He's the perfecter of the microvascular decompression procedures for a variety of things. And they were very common procedures in Pittsburgh, like the wind in the trees. At that time, many tumors of the brain were operated, but no distinct specialty existed. Neurosurgeons often worked in silos, and they disdained collaboration with ENT or plastic surgery. There were some early examples of collaboration: Ray and McLean, Bill Billhouse, Smith and Ketchum, and Joe Maroon and Vic Schramm in Pittsburgh. Here's Dr. Janetta talking to a patient. So as I was doing my residency, my principal interest was cerebrovascular surgery. And as some residents are doing now, I did a short in-training fellowship with Dr. Charlie Drake in London, Ontario in 1981. For about 6 weeks, I went and observed him in very cold and snowy London, Ontario, observing these great people. Dr. Drake was very kind to me because he's a personal friend of Dr. Janetta. And when I was not in the operating room, I watched many unedited videos of Drake and Peerless. And Dr. Drake is considered, I do consider him to be one of the great heroes because he took on some very difficult problems, often in the face of complications and adversity. One thing about Dr. Drake, he didn't like foreigners remaining in North America to work as neurosurgeons. He was opposed to this concept because he thought foreigners took jobs from Americans. However, in later years, he was very friendly to me and he expressed appreciation of my work in some conferences. So 1982, neurosurgery residency was ending. The question I was faced with, what to do now? My main focus was cerebrovascular surgery. However, as I looked around and there were no good jobs available to me in academia, and around this time, Majid Sami from Germany, Hanover, Germany, came and gave a lecture. He's a very, very charming person who could charm anyone. And Dr. Janetta made me an offer to go to Germany and learn peripheral nerve surgery. It must be, I didn't know this at the time, but I was the third person to whom the offer was made. First one was Dr. Steve Haynes, my senior, who declined and took a job at the University of Minnesota. Second one was Parvis Bagai, who then went to private practice. And then that was the third one, and I was a sucker, so I took this job. And to learn about peripheral nerve surgery, I had to learn German, and I learned it with a guy from Bangladesh. And I decided to go and work in Germany for about 6 months. One important case which challenged me as a junior attending, I started, and then I was there for like a couple of months and went to Germany. We had a patient with no carotid arteries, had just two vertebral arteries congenitally absent, and had a presented with a ruptured giant aneurysm of the vertebral artery. We exposed it to a standard approach. The aneurysm ruptured as we were dissecting it. We had proximal control, but not difficult distal control. There was a lot of bleeding and difficulty. Got it controlled eventually. But the exposure was very bad due to inadequate approach. The patient survived the surgery, but he could not breathe when he went to sleep. When he was taken off the ventilator, eventually the family decided to end his life. So this started me thinking, could a better and a more lateral and better exposure provided a better exposure of the aneurysm and saved his life. So I worked in this place in Germany called the Nordstadt Krankenhaus. It means the hospital in the north part of the city hospital in Hanover. And although I was sent to learn peripheral nerve surgery, of course the place had everything going, and Majid Sami had shifted his attention to this area which he called skull-base surgery, and he had formed some collaboration with other ENT surgeons and so on and so forth. His primary focus was acoustic neuroma surgery, but he also thought that he should work with other people. And he was a great philosopher. He was like another father figure to me, other than Dr. Janetta. Spent a lot of time trying to convince me that this new field would be the right field for me, and not cerebrovascular surgery, because no one can be better than Professor Yazagil and Charlie Drake. So many of course, Dr. Janetta's residents and Sami's trainees became my friends for life. So after I finished with Majid Sami, I went to work with Ghazi Arsigil, whom many of you would know. He's also known as Mahmoud M. Ghazi Arsigil. He was a Turkish man who ended up in Zurich and underwent a very difficult period of training under Professor Krayenbuhl. And then eventually he's an innovator of the SDMCA bypass procedures clinically. His knowledge of anatomy and the way he handled the blood vessels was amazing. He danced around the brain like it was his home. He was like a snake charmer, charming snakes from India. He had a very gruff and rough personality. It was a completely different atmosphere in Zurich. It was very tense, and he would talk to you, but he can't talk back during surgery. And you can't move. If you move or say anything, he said it disturbed him. He did like me, although he generally didn't like a lot of observers. Because I came from Dr. Janetta, he was his friend, and also for whatever reason, he liked Indian people. So he kind of liked me. And then on Fridays, I'd go and watch a man called Ugo Fisch, who is a god of ENT surgery. He was doing some skull-based procedures. So I came back to Pittsburgh in 1984, and I was appointed as an assistant professor in neurosurgery. And I agreed to work with Dr. Janetta as his junior partner, which was a demeaning concept to many of my colleagues at the time. And you have to remember, my colleagues were very illustrious people. Dr. Dale Ensford, who pioneered the intraoperative CT scanner, and he was a big promoter and innovator of the Gamma knife. Dr. Leland Albright, Paul Nelson, who's very important down later on. He was the chief of surgery, just like Dr. Lewis Kim is today. Joe Maroon, the neurosurgeon for the Steelers, and also featured in the movie, not in such a great light. Howard Jonas is a designated CV surgeon. And over the years, two very important people initially started as my fellows and then quickly became my partners, Dr. Chandranath Sen and then Dr. Donald Wright. They were very crucial in the development. This is Presbyterian University Hospital building in Pittsburgh. So my primary interest was still skull-based surgery, cerebrovascular surgery, but Dr. Howard Jonas was a designated CV surgeon, and he very jealously guarded his position. So I was allowed to still work on some things, but not do a lot of innovative stuff. On the other hand, nobody wanted to work with the ENT surgeons in Pittsburgh who were constantly getting into problems. They were used to take the carotid artery and create a stroke. They'll have CSF leaks, etc. And we had to take care of them as neurosurgeons. So I decided to work with them just to avoid complications they were creating. But the chairman of ENT really welcomed me, and his name is Eugene Myers. And I started work with Vic Schramm, a head and neck surgeon, and Donald Cameron, a neurotologist. But because I had worked with Hugo, or observed Hugo Fish, really, Hugo Fish was considered like the demigod of ENT. They said he's a neurosurgeon who had worked with Hugo Fish. So they all thought that I was somebody phenomenal. So at this time, I established the first skull-based cadaver lab at the University of Pittsburgh. I got a bunch of discarded OR equipment, and then Scaife Hall is the medical school building right next to the hospital. Jan Hart was an anatomist who also owned a funeral home, and he knew how to preserve cadavers without it being so smelly. And this technique is now used by everybody all over the country. And he provided me with some preserved cadaver heads. I had a research fellow, and every Saturday I worked in this lab, and I was randomly drilling structures of the skull base, learning anatomy, just focused on targets of getting in intracranial, and everything was just things in the way, basically. Around this time, also Dr. Vinko Dolens from Ljubljana had talked about cavernous sinus surgery, and I was trying to develop methods to reconstruct the cavernous sinus, cavernous ICA, and the cranial nerves. Gradually, this evolved. This cadaver lab became a translational lab. Basically, a lot of these things were translated into a variety of approaches, bypasses, and so on. So when the question is, how do you design a complex skull-based operation, something that didn't exist? So how do you approach a tumor optimally, how to remove it safely, how to reconstruct arteries or veins, and how to reconstruct the skull base or cranial nerves? So all of these, I worked out in my mind in the cadaver lab, and also to some extent by trial and error in patients, but I had very good collaborators. Now, I attended an international conference of microsurgery in a private hospital conducted by one of the competitors. For the first time, I learned about what's called free flap transfer by plastic surgeons. This was being discussed in different parts of the body. So I came back and I persuaded our local plastic surgeon to do it for a patient after skull base resection. So we had removal of a recurrent malignant tumor of skull base, along with Vic Schramm. We did a carotid artery replacement of the vein graft, and we used the rectus abdominis flap for reconstruction. And then this became a very popular theme. We went around and we wrote a bunch of papers and gave a lot of presentations. So we then started to have a number of conferences to discuss this. We had some courses, conferences, etc. In 1986, the North American Skull-Based Society was established, and you'll see some illustrious names here: Dr. Ken Sugita, Dr. Fukushima, Sama Al-Mefti, Takeshi Kawase, and others. Don Becker also claimed to be a skull-based surgeon. I say claimed to be. So in 1987, Vic Schramm left, and we had a big void. So I recruited this man, His name is Ivo Janica. He is dual trained in ENT and plastic surgery. So he was a very good surgeon, a very cold personality, originally from Czech Republic. He grew up in communist country and he had that personality. So we established the world's first Center for Cranial-Based Surgery. The idea was to have a co-directorship and a collaboration with the different specialties: plastic surgery, neurotology, ophthalmology, diagnostic and interventional radiology, and nursing. And the concept, two things about Pittsburgh. One is Pittsburgh was a center for innovation. Dr. Janetta himself considered to be himself to be the great innovator, and he pushed others to innovate. He wasn't jealous, initially at least, about other people succeeding. However, uh, as it evolved, he also became somewhat jealous because I was getting so many visitors, and microvascular decompression sort of dropped off as a focus. Dr. Chandranath Sen worked with me very closely, but one of the major reasons, my main supporter, was Dr. Paul Nelson, who supported me through some very difficult times. And also Dade Lunsford and Ladislaw Steiner, although they were focused on Gamma Knife, they were also my supporters. Dade was my tennis partner, and then he usually let me win tennis games, of course. All of these people remain my great friends. So this is an early picture. You can see the very handsome young Sekhar, the standing there, and some of the others, nurses and so on. We had this man, Don Kemmer, Barry Hirsch, and Steve Hess, neurotology. Chip Youngrice from interventional radiology. We did a lot of procedures in the OR. For instance, he would come to the OR and I'll say, Chip, please do angioplasty of this vessel. So we had this CM fluoroscopy. He'll float a balloon up and do an angioplasty, or and then one of those cases, the artery ruptured right during the procedure. Or he would provide some balloon assisted proximal control, etc. We did all sorts of things, crazy stuff. And then Howard Jonas, who was an intense competitor, became an ally because we had a shared blood flow in cerebral blood flow and skull-based approaches. We also established a cadaver training lab for residents and fellows, and we worked on combining microscope and the endoscope. Dr. Al Roten became a great ally and friend because he was doing all anatomical work and I was doing translational work, so he liked that idea. So we started training fellows and residents over time, and many illustrious people trained either fellowship or in training and so forth. And all of those people contributed to the growth. Not everyone who trained gave something back. So what did we accomplish in the first 10 years? New or improved approaches, many of them, better methods of resection, vascular reconstruction, cranial nerve reconstruction, and then skull base repair. So here I'd like to talk a little bit about the analogy with the symphony. Felix Mendelssohn is one of my favorite composers. He died very young, but left some phenomenal works. He conceived the Symphony No. 4, it's called the Italian Symphony, after a trip to Italy. He was very impressed with the sunshine, landscape, and the musical scene as compared to Germany. And then he was commissioned by Philharmonic Society in London. His sister Fanny Mendelssohn is also a composer and musician. And he said, this is the happiest piece I've ever written. But he revised it many times. And the original version remains as the first perfect one. But just think about the symphony for a moment. And here is one version of his symphony. And this is by one of the also another piece. Notice that the way the symphony is written remains the same, but the conductor and the players, they all work together in unison, and they make the difference. It looks different, they make a difference. The overall central theme remains the same. So you have different conductors, different concert teams, concert halls produce somewhat different but similar music. So skull-based surgery is a symphony. The neurosurgeon remains the producer and the conductor. You have a lot of different things that go through your mind. Is surgery the right choice? What type of operation should be done? What approach or approaches should be used? Any special imaging? Which surgical team should be involved? And how do you go about doing what you're doing? How do you repair? How do you manage complications? Pathology, molecular and genetic studies, post-operative therapy, etc. Managing the patient follow-up, the depression, of course, maybe the patient or the surgeon, if there are complications, return to work, etc. So the neurosurgeon remains still the center because we're always the people responsible for the complications. The North American Skull-Based Society was established in 1986 and became an early vehicle for getting together people who were interested in skull-based teams of people. There was a lot of exchange of ideas, very frank discussions. Some key elements were that we created these codes that all of us use today. Dr. Cohen Peavyhouse, he was very interested. He was from University of Virginia, and he helped us. And Tom Urgitano, John Leonetti from Loyola. Tom is now in nearby Montana. So they developed the billing codes. They got them through the AMA, which was very important for the survival of the specialty. We had a lot of skull-based courses. There was continuous renewal of the organization by the leadership, and this served as a template for societies around the world. And every time we had a meeting, we used to play tennis. I played tennis all over the world with different people. I'm not a golfer, but golfers played, and of course we had good spirits and food, etc., and very good discussions. One has to say that this group of people from Pittsburgh were called the Pittsburgh Mafia because every time we go to a meeting, we'll have like 40 papers. Then later on, the World Federation of Skull-Based Societies was established. There were competing societies. One was the Sami group and the Fish group, and I was a kind of a bridge between them because both of them trusted me, and I was a Sami guy, but I was respected by the Fish people. So anyway, this World Federation meetings happen. I mean, these are more political than really exchange of ideas meetings, and of course we go to nice places in the world. So as we established a Center for Cranial-Based Surgery, there were questions raised about results by some anonymous people and a fellow about the results. And Dr. Janetta, I was getting promotion review, and he called me up and he said, Sheikh, there are people that are questioning the results, and there are some people have raised questions. You may want to mute yourself there. So Dr. Paul Nelson, I mentioned to you that he was the chief of surgery at Presbyterian University Hospital, chief of neurosurgery. He said, Sheikh, I'm going to commission an independent study. So let us take, give me your last 50 patients. So the last 50 patients were consecutively called by an independent quality assurance group, and they tallied the results, and they were exactly
pretty good. Interesting. Talking about history of skull base.
Somebody's need to mute themselves on an iPhone. Thanks.
So and then Dr. Janetta, didn't say anything more, and then Dr. Janetta was again upset when I decided to leave and go to GW as a chairman. Dr. Nelson again intervened on my behalf and said, yeah, Pete, it'll be really great to have one of your students as the chair somewhere. So anyway, he was a great supporter for many years. So just a couple of cases, early cases, I want to show you. This was a very difficult case, a patient with a very difficult meningioma. In those days, you didn't have MRI scan, only CT scan. You can see that very heavily calcified tumor and a clival meningioma. The brainstem is dark, which means there's a lot of edema on it. The patient was in very bad shape, quadriplegic with multiple cranial nerve palsy, etc. We did an angiogram, shows that the basilar artery is narrowed and bowed. So we did an initial transtemporal approach, and it was immediately obvious that this was a heavily calcified tumor. The basilar artery was going right through it. So I, was left with the idea, okay, we'll leave the patient to die or do something. So we designed this operation to take out the entire petrous bone, move the carotid artery forward. The facial nerve could not be preserved. We reconstructed it. Hearing was sacrificed. So the whole tumor was exposed, almost like you were looking at a convexity tumor. And then after hours of work, we were able to peel the tumor off the artery and preserve a lot of these perforators. And the patient made a remarkable recovery, still with facial paralysis, you can see, but made a wonderful recovery. This was a good stimulus. And I will talk a little bit about the development of high flow bypasses and for aneurysms and tumors. So the STA-MCA bypass was the primary microsurgery procedure when I was a resident. You'd go to meetings and the people say, well, doctor, we are doing also the STA-MCA bypass in our place. Okay, so we thought that that'll be the premier microsurgery operation. It, of course, lost its luster after the failure of the international bypass trial. And the cost trial, is very important now for Moye disease and syndrome and some aneurysm cases. The main problem, of course, is the volume of graft flow is low. And it can also create, of course, bidirectional flow with MCA or ICA stenosis. The major question that was being asked at the time, if the carotid artery is involved severely by tumor, or of course in those days giant aneurysms, this is before flow diversion stents, when do you need a bypass and when can you just take the vessel? We spent a lot of time studying this in Pittsburgh with various types of balloon occlusion studies, plus xenon blood flow, transcranial Doppler, induced hypotension, et cetera, et cetera. So we had the philosophy that we would only take the artery if the patient were to pass everything. I would go to meetings, and Dr. Spetzler was always in the panel with me, and he was totally opposed to this idea. He said, you can't take the carotid artery, you should always do a bypass. So what happened over time is that we studied our occlusion patients, and we found that the safe group, what we thought was a safe, was there a question? Safe group was
Misha, I don't think you're muted, just so you know, Misha.
Having complications due to thromboembolism. This was also confirmed by Tom Arigitano using SPEC studies. So our final conclusion was that surgical occlusion of the ICA is never safe without a bypass procedure. However, endovascular occlusion, meaning when you're doing it only for endovascular, an endovascular surgery, it's safe. But with surgery, you add additional things such as potential for blood loss, thromboembolism, et cetera. So it's not really safe. So Dr. Spetzler was actually right in a qualified fashion. So in the meantime, the evolution of the bypass, Dr. Thor Sant, Bill Lougheed from Canada, and then Bob Spetzler developed ECACA, saphenous vein grafts, for ischemia and some aneurysm patients. I had a patient in Pittsburgh who developed postoperative hemiplegia after the carotid was taken. The patient woke up and was plegic. And I had never seen one of these. I'd only read a paper by Dr. Sant where he was using a blade, shaving blade to cut through the artery, and then he would put the vein graft and then sew it and so on. It's a high failure rate. So I started doing this, and I developed this procedure of petrous ICA to supraclinic carotid artery in cadavers, and in patients also used subsequently by Dr. Fukushima and Spetzler. There were a lot of early controversies about this procedure, but some people like Gene Flam from New York, and then in Philadelphia, and Roberto Heroes, my former teacher, they all became enthusiasts. And then we had lots of cadaver courses and so on. And this is a patient that we operated in when I was in GW, a young lady who presented with 15-year-old girl, presented with a giant vertebrobasilar aneurysm. What you don't see here is a heavily thrombosed person part. She was rapidly declining, was stuporous and quadriplegic, no PCOMs or very poor PCOMs. So I did an initial saphenous vein graft to the PCA, but the saphenous vein was too big. But there's a big mismatch. The patient was going down the road. So what we did was we sort of took out the temporal bone in one day, preserving facial nerve. And then on the second day, we, under cardiac arrest, we did the bypass to the basilar artery itself, and then decompress or debulk the aneurysm. And this lady made a remarkable recovery. She then was featured on national TV. There was a big article in Washington Post, et cetera. She went on to become a psychologist. I just saw her about 2 years ago in DC. She's a good facial function, but no hearing on that side. And the vein remains pretty good. So this is what I was talking about. When do you need a bypass? And the reasons for bypass have diminished, mainly because of the use of flow diversion stents, but still there are a lot of cases. I'm talking about high flow bypasses. But there were a lot of problems with the saphenous vein, which the main thing is the flow mismatch. And also the vessel wall is a little different. They're not matched. So we started developing the radial artery graft. The main problem was vasospasm. They would go into spasm. So somehow I developed this idea. One of my colleagues said, well, one of my people in Japan keeps them distended. So I developed this concept called pressure distension technique, which really prevents a spasm. But in patients, this is, pressure distension as it's performed in a patient. But there are people that in whom the radial artery is not suitable. And then we developed this idea of the anterior tibial artery, which is actually developed right here, UW, along with our vascular surgeons. You can use saphenous vein or anterior tibial artery for bypasses. Cavernous sinus surgery was very, very sexy at one time, and then there were a lot of bypasses, again, a lot of detractors. But then came along radiosurgery. But then there are things that we have come to a kind of a compromise situation when we have a meningioma inside the cavernous sinus. When it is soft, and if, of course, they have to be symptomatic. When it's soft, you can remove the tumor within the sinus. If it's not soft, then you do a cranial nerve decompression and treat the patient with radiosurgery. Whereas other tumors, you can go inside the cavernous sinus and remove them, like benign tumors or chordoma, chondrosarcoma. Malignant tumors, you may have to sacrifice the structures and maybe do an ICA bypass. So there are some controversies in skull-base surgery at the moment. Endoscopic surgery versus microsurgery, but this is not a real controversy because now people are, doing both. But there are centers which focus or do only endoscopic, mainly endoscopic, like Pittsburgh. They do mostly endoscopic. We do everything here. And then there's a question about, of course, endoscope-assisted microsurgery, which I think has a lot of future. Then the issue of eyebrow and transorbital minimally invasive approach, mostly given up by people that are using a lot, but there are still people that think that this is, attractive to patients. Do you really need skull-based approaches? When can you use radiosurgery? And then we are now starting, obviously, with chemotherapy and anti-tumoral antibodies. The other thing is reconstruction becomes very important. Now in the area of aneurysm surgery, of course, we are evolving into what are the right methods, endovascular treatment, endovascular stent coiling versus clipping, bypass, etc. So this leads us to the topic of innovation. So something that I want to spend a few minutes on. So new ideas come to us all the time from the universe. Some people, of course, more receptive than others. When we see problems, we may think about solutions. Some are correct and some are not. And similar ideas have occurred to other people as well. I would say that imagination is a quality of the evolutionary brain, and even animals have imagination. And imagination, of course, is thought to be more important than intelligence, according to Albert Einstein. In humans, problem solving often follows defined pathways, but some people make tremendous leaps for unknown reasons. Examples of Newton, Tesla, Srinivasa Ramanujan, Einstein, Feynman, and others. Is this side of genius evolutionary or a residual of previous life karma? We can't say. However, translation of revolutionary ideas is very different and difficult. Some ability to take risks, persistence, and ability to weather skepticism. Examples, Robert Oppenheimer, Elon Musk, Sam Altman, Sergey Brin, Jensen Huang, all these people. But also equally important nowadays is the ability to assemble and motivate a highly skilled team. I tell my colleagues, leadership is about putting together a group of people and weathering everything that happens, namely idiots, imbeciles, dishonest people, but mostly good people, and then trying to lead them. And we see some really good leaders, Dr. Ellenbogen, Dr. Lewis Kim, and others in our department. It's important to remain curious. When we are children, we are very curious. But then as we grow older, this part of the brain shuts down. So my young son, when he was 4 years old, he used to ask some very searching questions. He said, "Dad, what will happen to you when you die? Where will you go?" And then he used to ask me, "When I grow up, will I also have a family like you?" So this kind of curiosity, we have to preserve it. And in terms of neurosurgery patients, every patient presents a unique set of problems. Either it's scientific, technical, or human, and we have to think about why we're doing something and what can we do better. And if we have complications, how do we prevent it most of the time? Collaboration is very important for learning. So all of our co-workers have something to contribute to our work. Remain respectful and attentive to what they're saying. I pay a lot of attention. The people think that I don't, but I pay a lot of attention to what everyone says. For example, I have Melody and Sharim J, who are frequently, and others that it's scrub techs. I listen to what they're saying, not only about me, but about my residents and fellows and so on. But I also pay attention to our co-workers like janitors, hospital workers, etc. The other day I was in the OR and Caroline, my fellow, was saying something. She was listening to sounds in the OR. We have weird sounds. She told me, "I learned to listen to the sounds in the operating room from monitors so I can detect bradycardia." This is very important. Yazi Yazikal used to say the same thing. He used to listen to the sound of the suction. We used to call it Zog in German. And he demanded absolute quiet in the OR to allow him to concentrate. So your colleagues should be able to contribute, to be able to speak to you very freely in a constructive way, and vice versa. They are doing or saying something which may help you to innovate or solve problems. We have to try to learn from other specialists. So we lost this art nowadays. We have retina surgery, and I have not seen what retina surgery is about. I try to speak to orthopedic surgeons. I'm constantly trying to learn spine surgery from Fungi, and I offered many times to him that I'm going to put some screws, etc., but he keeps me away out of the OR. A lot of the specialists who work with us are very good at what they do. It may or may not be applicable to us. Family is very, very crucial. Nowadays, our residents and fellows are very well focused. In the past, as neurosurgeons, we didn't focus on that. But it really is something that we need to achieve a balance in life. We need to be able to resolve conflict, help others, and learn techniques like meditation. So, advice to our young surgeons: learn everything you can from your mentors. Learn something about emerging technologies which will shape your world. Be innovative, collaborative, and adaptive. Expect to be retrained and redeployed many times in your potential career. Maintain your personal, mental, physical, family, health, etc. So I'd like to thank Dr. Ellenbogen, Dr. Kim, all of my colleagues. You are my family. Thanks again.
Great presentation, Sheikh. Thank you so much. Questions from the audience, please. This is a real resource to have Dr. Sekhar speak to us this morning, so please don't hesitate to ask him really hard questions. I'll just start. I think you mentioned collaboration as a key, and I couldn't agree more. I think that one of the concerns is the financial incentives and the economic boundaries that prevent us from collaborating properly. Can you envision a future where we're skull base and vascular are more kind of a team-based enterprise rather than a departmental-based enterprise? And obviously in the context of what we're doing with NIR right now, but
Yeah.
appreciate your thoughts.
This is a very, very important question. The question is, when you're doing collaborative surgery, obviously we are sharing our RVUs with other people. There is an incentive and a disincentive. The disincentive is that when you share with others, then you obviously lose the RVUs. And then also, let's say that you have a patient with an aneurysm that comes in, you decide that this should be treated by endovascular method rather than microsurgery, then you lose that patient. And what happens there? So the funny thing about this is in Pittsburgh, we at that time, the time that I was growing up, we never thought about the money aspect, mainly because we were all paid very low salaries. My salary right after I became a junior attending was $55,000. Initially it was given 50, but then after I begged and pleaded with Dr. Janetta, he increased by 5,000. And as a junior attending, I was making 125, and then as a professor, I was making 225. So somehow this financial aspect was not important, but I think it is very important. And I think we need to have both an incentive for people to work and do things. At the same time, there has to be some incentive for collaboration. So there has to be some joint ownership of the results and the financial aspects. I think these are both important. I don't know how best to achieve that. Obviously, when the patient does well, everybody's happy. For instance, Dr. Chris Moe may want to do something in a particular way, you want to do something in a different way. But if you can talk, and I think the personal relationships I feel are very, very important. It's very important to have personal relationship with a person and cut across lines. And this also applies to training. Skull-based surgery, vascular surgery, all these things. How do you train people? In a joint environment? It's very important.
Jeff, did you have a question or comment?
I did. Thank you. And thanks for these reflections. Apologize for being off camera. Sheikh, my question is your philosophy on receiving feedback. And, you told one of the stories and others I know of where your work was criticized. And so how do you balance that? You have to be confident to make the kind of decisions that you and all of us make, but you still have to be open to the idea that you're doing something wrong. And I find that can be a very difficult needle to thread. So I'm interested in your thoughts on that.
Yeah. I was saying, I think this is a very, very important question. How do you balance critique with what you're doing and innovation. And I think that we all grow by our criticism. The important thing is to have an environment where people can criticize you in a constructive way. In our area of vascular surgery, I consider Dr. Mike Levitt to my greatest ally. Dr. Lewis Kim is a very, very balanced person. He thinks about surgery, he thinks, microsurgery, he thinks about endovascular. Dr. Levitt favors endovascular surgery, but also favors always evidence-based medicine. So when we present cases, he says something, it seems that he's saying something very opposite of what is being said. But I listen very carefully to what he says because he provides the alternate point of view. Oftentimes in medicine, we don't have evidence base for what we do. There is for certain things and there is not for other things. And at the end of the day, you have to be secure in yourself, in what you're doing, but you also have to be open to critique and new ideas that you can evolve, with time. It's much easier, I would say, in an academic environment as compared to a private practice environment. Private practice, you may not have, critiques and detractors. Academic environment, on the other hand, we have our egos, personal egos involved in an academic environment. And on the other hand, it's equally important to be persistent about things. Otherwise, you can't accomplish anything. And why I talked about my early life is because I faced a lot of problems with different things, different forms of critique. People telling me you can't do this. When I was in the U.S., people said, "Well, you're a foreigner. You're not very good." And then Dr. Janetta, when I was hired, he said, "Well, maybe you can work at the VA and not in the main hospital." Even though I was, one of the top graduating students, etc. So I sort of, that shaped my early life, and if you grow up, in a situation where no one is saying anything bad about you, then you just don't have the persistence. So how does a person like Elon Musk come around out of nowhere? And of course, we may all have critiques about what he does, but he innovated these things like, because he didn't start Tesla, but he made it successful, SpaceX, et cetera, et cetera. How does that happen? So we need this quality of persistence is equally important as the ability to respond to critique. I hope that addresses your question.
Other questions from the audience, please.
Dr. Sekhar, this is Jake. Thank you so much. As a young, growing skull-based surgeon, and having young people around us in the department, so much energy is focused on innovation and growth. But I'm wondering if you could just comment or reflect quickly on the importance of fundamentals that, you obviously spent time traveling around the world, growing your skill set. That can be more challenging today, but we have opportunities like the lab and visiting professors. And if you could just comment on making sure we're doing the fundamentals right to grow as, leaders within our field.
Yeah. Surgery is, at the end, it is surgery. Surgery is applied anatomy at the end of the day. So we really have to be very good with our anatomical knowledge. That's number one. Number two, operative technique. Before I started doing bypasses, this was very common in Pittsburgh, but some people were better than others. I did bypasses on rats. When I was resident at the VA, I worked on multiple rats, doing STM-safe bypasses. Then my research projects, I was doing bypasses on dogs, which is more difficult than human. And I was trying to develop a model of AV fistula in dogs and some other things. And now, fast forward, we have this home microsurgery lab. It's not for everyone. If you're interested in microsurgery, you do that. Similarly, endoscopic surgery, there are simulators. The big problem for all of us is time. We just have limited amount of time. So we have to develop some sort of focus. So that's number one. You have to become, your basic technical skills have to be really developed. The third is that you have to look at everyone and what they do. What Dr. Sekhar does is different from Dr. Kim, Dr. Ferreira, Dr. Ellenborg, etc. Everyone is something important to contribute. And in the old days, we used to finish training, and then we would go here and there and observe other people, other surgeons operate. Now that's become, of course, people do fellowships, but then beyond that, we don't do very much. That has a great value because every person is doing something that you can learn from. At the same time, I think we have to be constantly thinking, what is this really what I want to do? What can I do to do it better, et cetera, and try to adapt it to your own environment. I think that obviously, as a young, skull-based surgeon, you and Sam, your futures are remarkably, amazingly bright. So the question is, what areas will you develop that will blend the current techniques with future emerging technologies? And this you will only know after the first 5 to 10 years of your practice are very important. That's when you mature as a surgeon. But then you start, more and more innovation. Obviously, we are limited by the fact that we are dealing with patients. So we have certain boundaries. We can't innovate like in the cell phones or computers or whatever. There they are limited by sales. Here we are limited by our patients' lives. But I think innovation is very important.